She'll be presenting the case of decoding diagnostic dilemma, juvenile double seronegative myasthenia gravis.
Good morning, everyone. So my paper is on decoding diagnostic dilemma in juvenile double seronegative myasthenia gravis. So myasthenia gravis is an autoimmune disorder usually caused by antibodies against acetylcholine receptors and anti-MuSK antibodies. However, when these are absent, we call it as double seronegative myasthenia gravis, and it leads to delayed diagnosis and treatment. So the objective of my study was to describe clinical features, serological profile, and response to neurophysiological tests, specifically in children with double seronegative myasthenia gravis. It was a cross-sectional retrospective analysis, and local ethics committee approval was done. So we included all the children presenting to us with fluctuating muscle weakness and fatigability, in whom acetylcholine receptors and anti-MuSK antibodies were negative, and they were labeled as double seronegative myasthenia gravis patients. And after that, we performed extended antibody testing like LRP4, ASCA, and co-opting with RNST. So factors which were analyzed at 18 months follow-up were age of onset of disease, distribution of weakness, generalized or ocular, myasthenia gravis composite scale, serological and neurophysiological profile with therapy and outcome. So the outcome measures were defined as adequate response for more or equal to 3-point fall in MCG score with pyridostigmine and steroids, partial response with less than 3-point fall in MCG score and pyridostigmine steroids plus need of immunosuppressants, refractive response with no improvement with steroids or at least 2 other immunosuppressants. So the results were, we had 52 children over 3 years with possible myasthenia gravis symptoms, and out of those 8 patients were negative for both the specific antibodies, and they were termed double seronegative. Mean age was 12 years and male to female ratio was 2:6. In these 8 children, we did all the extended antibody profile, and out of them 3 were positive for LRP4, and the MGC score was 3, and the response was adequate. This also told us that LRP4, the patients who were positive for LRP4 had good prognosis, and co-octine positive were 2 patients, and one of them required immunosuppressants. So this tells us that prognosis is little bit poorer than patients with LRP4 positivity. Out of these 8 patients, 3 were inconclusive, and ASC was positive in 0 patients. All these 8 patients were subjected to RNST. So 5 were positive for RNST and 3 were negative for RNST. Out of these negative RNST patients, 1 was positive for single muscle EMG. So this tells us that single fiber EMG is the most specific and most sensitive test for myasthenia gravis. So to emphasize this, this was a case of intermittent exotropia. So it was such a good mimicker that it never developed ptosis. It was always intermittent exotropia, and the patient was operated for the same. And then it was thought that there is residual exotropia, but after 6 months of surgery, first time he developed ptosis. After that, IcePack tests were done and the antibody panel was done, and he was still negative for the 2 main antibodies which are routinely done, and he was positive for LRP4. And after starting medical therapy, he actually improved. So this is how double seronegative myasthenia gravis can be missed and confused with other factors, because not every case presents very typically with ptosis as a first sign. So what we already know is that 15% patient with generalized myasthenia gravis and 50% with ocular forms of disease are double seronegative. It has been already proven in literature. But multiple antibodies involved of most common are anti-LRP, anti-titine, and co-octine. So most studies are done in adults, but this study we just studied children. So what we found in this study was pediatric ophthalmologist may be the first contact doctor in a double seronegative patient. So if we do a extended antibody panel and pick this diagnosis early, we can actually save them from going to a generalized myasthenia gravis. So LRP4 is most common antibody with excellent prognosis. Co-octine positive cases may need immunosuppressants, is what we found from our study. And single fiber EMG is the most sensitive, even sensitiver than RNST. So successful myasthenia treatment requires early diagnosis, high clinical index of suspicion, and diagnosis is a dilemma. So a cocktail of clinical tests, serological tests, and electrophysiological tests are needed. So treatment adheres to guidelines and prognosis remains excellent if we pick this up early. And so yes, we should have high index of suspicion in children, especially if we are seeing the symptoms, clinical features, but the most commonly done antibody panel is negative. So that is all. These are my references. Thank you so much. So ma'am, we worked with a pediatric neurologist also for the systemic doses of pyridostigmine and steroids if needed. So till the symptoms, they start on a loading dose for 2 months, and after that for 3 months they put them on maintenance dose. And in a period of these 6 months, they see how they have improved clinically, and after that, after 6 months, they decide. If they have not improved, they start them on immunosuppressants or steroids. If they have improved, then they slowly taper the doses. Yes, ma'am, there were recurrence. In of one of the cases, after 2 years, there was recurrence, and they again put on pyridostigmine. Yes.
Apart from this serology test, did you see regarding the status of thymus gland in these children?
Yes, ma'am. In 2 patients, this was done. CT MRI of the
CT MRI was
yes,
done?
yes, yes.
And thymectomy was done in any of the child?
No,
Surgical?
ma'am. No, nobody had thymoma, so.
Nobody had thymoma in all these children?
Yes, ma'am, nobody had thymoma.
Go. Question? Yes, ma'am. Mic de do.
It's a nice case you presented, but since the beginning of our medical education, we are taught when you hear hooftops, think of horses, not zebras. So have you done the nutritional status of the child? What is the calcium levels? Is there any vitamin deficiency? And you want to diagnose untraditional illness where everything is negative, and you want to pinpoint a double seronegative myasthenia gravis and subject the child to a lifelong treatment without ruling out nutritional deficiency? That's point number 1. Secondly, why surgery? If it is because of acetylcholine deficiency and you treated it, why surgery? Thirdly, how frequent? What is the prevalence and incidence of this? So it should not be that you want to look for something and that is why you are looking for it.
Ma'am, first of all, in 52 patients, the prevalence of was about 8 patients in the whole 52 patient actually. Yes, ma'am. The pediatric neurologist had done all the lab tests, all the systemic lab tests before starting the treatment.
They might have been covered in the history part, maybe.
I just mentioned lab tests
Yes.
to
Yes. Thank